Okay, so today we are going to see chapter 24, Nursing Management of the Newborn at Risk, Congenital and Acquired Newborn Conditions. So acquired disorders means it's typically at or occur at or soon after birth. Problems or conditions experienced by the birthing parent during their pregnancy or at birth. Possibly no identifiable cause for the disorder, but congenital disorders means that's present at birth, usually due to some of the or some kind of malformation during antenatal period, during the time the fetus is developing. Typically some problem with the inheritance. That means sometimes maybe it's genetical too. Majority with a complex etiology. So some of the acquired conditions of the newborns are neonatal asphyxia, transient tachypnea of the newborn, respiratory distress syndrome, meconium aspiration, persistent pulmonary hypertension of the newborn, bronchopulmonary dysplasia, retinopathy of prematurity. So we'll see neonatal asphyxia in a little detail. So that means failure to establish adequate sustained respirations after birth. So actually failure to establish effective breathing. So that leads to hypoxia and acidosis. Inadequate oxygen delivery leads to anaerobic metabolism, lactic acidosis, and organ dysfunction, especially brain injury. As we said before, if the breathing is not happening, that also always affects the brain of the baby. So we can say pathophysiology is insufficient oxygen delivery to meet the metabolic demands of the baby's body. So what nursing assessment we do here? Uh, we look for the risk factors, newborn's color, that's part of the Apgar score, work of breathing, that is also part of the Apgar score, whether there is chest retractions or nasal flaring, use of accessory muscles, look for the heart rate, tachycardia, temperature, whether baby is hypothermic, and then the Apgar scores. So nursing management here is immediate resuscitation. As soon as the baby have asphyxia, that's a breathing problem, we need to do the resuscitation. Continued observation, neutral thermal environment, because these babies cannot take cool temperature, so we need to make sure the temperature of the room wherever the baby is adequate, warm enough. Blood glucose levels, as they can go for hypoglycemia. Parental support, it's very distressing for the parents, so make sure we are giving support to the parents, and also education to the parents regarding the condition. So now we'll see about transient tachypnea of the newborn. So this is a delayed clearance of fetal lung fluid expansion, sorry, delayed lung fluid. So remember I talked in the class that when baby is in the mother's womb, there is no air. So sometimes they have some lung movement. What they breathe inside is amniotic fluid. So they have that amniotic fluid maybe in their lungs. So usually that will go, out through during the time of delivery when the baby is crossing through the vaginal canal, or sometimes the positioning during the position can happen, but sometimes some babies retain the fluid. So this can cause mild respiratory distress, pulmonary fluid, maybe usually that removed slowly and incompletely. So usually the resolution happens by 72 hours of age. In this condition, what we do um, maternal sedation or birth by cesarean section, tachypnea, expiratory grunting, retraction. That means sometimes the transient ischemia is happen to the baby who have a maternal sedation or by cesarean section. At that time, that sedation can affect the baby also, and baby won't breathe properly. So that can affect their breathing. So that can help results in retaining the fluid in the lungs. So baby can have tachypnea, expiratory grunting. We can hear the grunting sound when you do the auscultation. Can see chest retractions, labored breathing, nasal flaring. Remember, chest retractions and nasal flaring and use of axillary muscles are main symptoms of um, breathing difficulty in a child. And sometimes mild cyanosis, respiratory rates possibly 100 to 140 in this case. So barrel-shaped chest, so that is um, because of the anterior posterior diameter of the chest is changed because of the breathing difficulty. So same like in COPD patients. Slightly decreased breath sounds. Chest X-ray shows mild systemic lung hyperation. That means too much aeration into the lung fields. Prominent perihilar intestinal marks and streaks can be seen. So this is mostly we select shadows, dense tissues in the chest X-ray. So sometimes mostly we see that in case of breathing difficulty, pneumonia, you can see these kind of perihilar interstitial marks in the chest X-ray. That means there is some breathing problems going on. So nursing management here is oxygenation, supportive care, intravenous IV fluids or gavage feedings. So gavage feeding means nasogastric gavage feeding. So babies maybe not because they cannot eat properly because they are already having breathing difficulty and also they can aspirate. So gavage feedings are um, safer here. Supplemental oxygen is needed if their oxygen saturation is low. Then neutral thermal environment, as we said, they need to keep warm. Respiratory distress syndrome. So here lung immaturity and lack of alveolar surfactant. So especially this happens in the premature babies. So the lung is immature. So we already said in the class, lung is the last organ to start working for the babies, or that only start working when the babies start crying. And lack of alveolar surfactant. So they don't have the surfactant, the lubrication there, so that can cause to distress syndrome. So uh, so what are the nursing management assessment here? So we assess for the risk factors. What factors are causing that? Whether the baby is a premature baby, whether the baby have any respiratory anomalies, any problem with the anomalies, and then whether the mother have some sedation or something like that. Those kind of risk factors we have to assess. Expiratory grunting. So when the baby take expiration, you can hear the grunting sound inside the lungs, and the nasal flaring as again nasal flaring and chest wall retractions are signs of respiratory distress syndrome. Always remember that. Seesaw respiration, that means the seesaw respirations means like a seesaw, like the one you use for cutting the trees and all. So seesaw, up and down respiration. Generalized cyanosis, you can see, not acrocyanosis. Remember we talk about acrocyanosis, that is only cyanosis of the extremities, that is normal. But in this case baby's generalized cyanosis, that the whole body is bluish in color, that's not good. That means the baby is in distress. Heart rate is above 150 to 180. Fine inspiratory crackles you can hear during auscultation. Tachypnea rates breathing rates are above 60. Silverman Anderson index score. So that is the index score they use for maintain for the respiratory distress syndrome. You can see that in your book figure 2040. So you just can have a look and see what is that. And then chest X-ray. Chest X-ray, as we said before, hypoaeration. So sees as there is not enough air is going into the lungs, and then under expansion, lung is not expanded well, and then ground glass pattern. So you can see like ground glass pattern, like a smooth appearance of the lung. That is because of the sometimes because of the collapse of the alveoli of the lungs. So that shows respiratory distress syndrome. So here you can see the scores, how they are assessing the scores here. So here features observed, we look for the chest movement, intercostal retractions, seatward retractions, nares dilation, and then expiratory grunt. So for each activity for chest movement, they give 2, 1, and 0. That means if they have a normal breathing, that is up and down, that means seesaw respiration. So that's getting a score of 2, and then lag on respiration getting a score of 1, and then synchronized respiration getting a score of 0. So here intercostal retraction, so there is no retraction, and then getting the score of 0. If there is just visible retraction, getting a score of 1, and then if there is a marked retraction, getting a score of 2. So C-fold retractions here, there is no Z-fold. C-fold process is the area where close to the C-fold process here on the sternal area, right? So in the sternal area here. So if there is any retraction happening, that there is no retraction, give a point of 0, and then just visible retraction like this. See, you can see the retraction here. Then 0.1. And then even if you get severe marked retraction, see, you can see the depression here in this area below the C-fold process of the sternum. So that give highest score. So the more problem, more score the baby will get. So nares dilation. So this is the no nasal flaring. This is called nares dilation, is called the nares flaring. So there is no flaring, 0. If there is some flaring, minimal flaring is 1, and there is marked, there is too much flaring of the nares, then we give 2. Expiratory gland, if you cannot hear anything, then you get 0. So remember, all these small scores, less scores, shows that baby is more normal. And then the scores improve, the condition also getting worse. And then the audible by stethoscope, if you can hear the expiratory gland using the stethoscope, you give 1, but you can hear the expiratory gland without a stethoscope. If you're keeping your baby's chest or your ear towards the baby's chest, you can hear that without a stethoscope. So then you'll give a score of 2. So that's how we calculate the Andaman score here. And then respiratory distress syndrome, nursing management, supportive care, close monitoring as always. So we need to monitor the respiration, monitor for cyanosis, monitor for heart rate, and then the respiratory modalities. So what kind of modalities the baby needed. Sometimes ventilation, CPAP, and PEEP, that is ventilator. Baby need to put on a ventilator machine. And then the exogenous surfactant. So we have to give the surfactant, that is a lubrication liquid from outside, and also oxygen therapy. As I said before, surfactant can be they can give artificial surfactant, or also they can give dexamethasone to help the baby to produce more surfactant. Antibiotics for positive cultures. And then if we send all the cultures, all the body fluids, blood, and then if there is any CS, sometimes CSF also they send for salt culture, or sometimes they send like a liquid, whatever the fluid or the mucus coming from the chest, they send it for culture. If there is anything positive, then they have to treat it with antibiotic. Correction of metabolic acidosis also happening here. And then fluids and vasopressors. So baby needs to have IV fluids and vasopressors for there if the blood pressure is too high. So most of the time, people with the respiratory distress syndrome, they are in NICU. They don't keep them in the general unit. So usually vasopressors are giving in the NICU or ICU setup. Gavage or IV feedings, because baby cannot take anything by mouth. Most of the time baby is intubated, or baby can aspirate, so we give IV feedings or gavage feedings. Blood glucose level monitoring, so because they're not feeding properly, so not like breastfeeding every 2 hours or so they can have a hypoglycemia, so check the blood sugar level. Clustering of care, prone for sideline position. So when you do the care, do all the care together. So if you are going to take care of the patient, baby, do the cot care, do the baby bath, do the swaddling, diapering, all the care, medication, everything at the same time, and then leave from there, because every time you move the baby, every time the baby move, that's too much energy baby need now. And then when the baby need too much energy, the baby need to baby cry, and then they start breathing fast, that give them more distress. So to prevent that, the basic idea is to keep them calm. Prone on side lying position, so keep them on prone or side lying position. That helps them to take the pressure off on the chest, and also if there is any drainage through the mouth, so that can drain out. Parental support and education. It's very distressing for the parent when the child is having respiratory distress syndrome, and then seeing the breathing of the baby is very distress for the parents. So that make sure we give them support. So meconium aspiration syndrome. Here, inhalation of particulate meconium with the amniotic fluid into lungs secondary to hypoxic stress. As I said last time in the class, in mother's womb there is only amniotic fluid, and then sometimes there is a distress happening, any respiratory distress happening, baby pass meconium into the amniotic fluid, and the whole amniotic fluid can get stained, and then baby can breathe this into the lungs, and then that can cause, that's called meconium aspiration syndrome. So what are the nursing assessment here? We look for the risk factors. The risk factors are, if baby have distress or mother have any problems, so look for all the risk factors of meconium aspiration. Staining of amniotic fluid. Look at the amniotic fluid and see it's like a greenish yellowish color. Nails, skin or umbilical cord. So not only baby skin, baby's nail, skin, umbilical cord, all can be stained yellow greenish stain from the meconium. It's a barrel shaped chest, that is same like in respiratory distress syndrome. The anterior posterior diameter of baby's chest is more, so then the shape of the chest will look like a barrel, like in a COPD patient. Prolonged tachypnea, so and then increasing respiratory distress, intercostal retractions, end expiratory grunting, and cyanosis. Those are all the symptoms of respiratory distress you can see in a meconium aspiration, because meconium aspiration causes respiratory distress. Chest X-ray, patchy, fluffy infiltrates. You can see that from the meconium, and then hyperation with the atelectasis. So atelectasis is a collapse of the alveoli of the lung. Then arterial blood gases can be varying, so sometimes that can be abnormal. Then metabolic acidosis also can be happen here because of the oxygen, the air exchange. Meconium aspiration syndrome. Nursing management, suctioning at birth. So as soon as the baby delivers, suction, adequate tissue perfusion, decrease in oxygen demand, and energy expenditure. That's how we cluster the care. So baby does not need to spend too much energy on every time test the baby. Neutral thermal environment, so it should not be too cold or too hot. Should be perfect like a mother's womb. Send parental support and education, very distressing for the parents, this one also. So give them education, give them support, tell them about the condition, and then that helps them to get some relaxation. Persistent pulmonary hypertension of the newborn. Here marked pulmonary hypertension causing right to left extrapulmonary shunting and hypoxemia. Pulmonary vascular resistance remain high. So the pulmonary resistance is high here, vascular resistance is high here, so that causes blood to shunt from right to left through foramen navel. So now the right side of the heart have more pressure, so that creates the shunt. Remember we talk about the foramen navel, so that, and then ductus arteriosus and all, so that the shunt causing too much pressure on it, and then so that can cause blood bypassing to the lungs. Profound hypoxemia can be happening in this case. Assessment, tachypnea within 12 hours after birth. So baby was born normally, and now after 12 hours of birth, baby having tachypnea. Marked cyanosis, grunting and retractions, systolic ejection murmur. So you can hear the murmur when the systolic ejection, so the blood ejecting from the lungs, from the heart, then you can hear the murmur through there. So that is mostly because of the blood is passing through the foramen ovale, so you're hearing the murmur. Echocardiogram, right to left shunt. You can feel the right to left shunting of blood, that is through the foramen ovale blood is going. So suppose after birth, after once the baby start breathing, that foramen ovale is supposed to be closed, but in this case that remains open. So nursing management here is monitoring for oxygenation and perfusion, blood pressure, whether some days the blood pressure can be high because of the right to left shunt, and also increased resistance in the right side of the heart. Immediate resuscitation is needed. Oxygen therapy should be administered. Respiratory support. So maybe the baby need a CPAP or PEP or something like that. So gives respiratory support. Medications should be given according to the doctor's orders when you give medication to pediatrics. So always make sure check the orders properly, because pediatric medications are very highly specific, like based on their weight and height. So clustering of care, so do everything together, as you said before, parental support and education like before. So bronchopulmonary dysplasia, so it's referred to as a chronic lung disease. So it's a chronic lung disease associated with the newborns who have a lung injury, need a continuous oxygen after initial 28 days of life. Prolonged oxygen therapy and positive pressure ventilation damage immature lung tissue, inflammation, fibrosis, and impaired alveolar development can occur. So possible causes are surfactant deficiency. So why bronchopulmonary dysplasia happening? Because of surfactant deficiency, pulmonary edema, lung immaturity, barotrauma from mechanical ventilation, and then fluid overload. So these all can cause bronchopulmonary dysplasia. Therapeutic management in case of bronchopulmonary dysplasia is administration of steroids in the birthing parent. So antenatal period, the mother should get the steroids, so that helps with the baby to produce surfactant, and then an exogenous surfactant to baby once the baby born. So give exogenous surfactant, artificial surfactant to the baby to produce surfactant in the lungs. So nursing management here assess a history of risk factors. Males are more prone for it. Preterm birth, less than 32 weeks is more prone. Nutrition deficiency. White race is more prone. Excessive fluid intake. Patent ductus arteriosus, that means that ductus arteriosus is not closed yet. Severe RDS treated with the mechanical ventilation. RDS means respiratory distress syndrome. And then more than 1 week of sepsis. So this all can go. These are the things you look for. And then signs and symptoms can be tachypnea, poor weight gain, tachycardia, sternal retraction. As I said before, the sternal area can be, you can see the retraction there, wheezing, abnormal blood gas results, hypoxia. So PCO2, SpO2, all those kind will be less. So nursing management here is continuous ventilatory and oxygen support, optimal nutrition, administer bronchodilators, anti-inflammatory agents to prevent inflammation, diuretics as needed because baby have a fluid in the lungs, so diuretics helps to baby to excrete the fluid from the body. Monitor newborn's respiratory status, provide high calorie diet plan, and then because baby need a lot of energy, but through the breathing, stressful breathing, so make sure high caloric diet is ordered for the child. Educate parents and family about ongoing care if needed. Retinopathy of prematurity. So this is a developmental abnormality affecting immature blood vessels of the retina. So high oxygen suppresses normal vessel growth. When O2 is required, abnormal fragile vessels proliferate. Risk of retinal detachment and blindness can cause here. So 5 stages of mild to moderate based on the severity can be, we can have 5 stages of retinopathy. Locations by zones in the retina and proportion of the retinal circumference. This is more like, affecting the retina of the baby. So because of the immature blood vessels in the retina. So that can actually, like the severe cases can lead to retinal detachment also. If a newborn is premature, vessels may cease to develop. So once the baby is premature, the vessels don't develop anymore. So that can cause that. So ROP, retinopathy of prematurity, typically develops in both eyes due to hyperoxemia because of the assisted ventilation and high oxygen pressure. That's why when we give oxygen to the patient, make sure do not give too much oxygen. So from giving too much oxygen, baby can develop retinopathy of the prematurity, or can develop retinopathy. Excuse me. It can also lead to acidosis and shock in the baby. So the key signs of risk are: baby is less than 32 weeks, baby is less than 1,500 gram, and prolonged O2 application or prolonged O2 receivement. So this can lead to retinopathy. That means a baby only 1,500 gram and is less than 32 weeks old, and if somebody is giving them oxygen prolonged time, so that can lead to retinopathy of the prematurity. So here's the 5 stages of retinopathy. You can see retinopathy one here. Stage 1, optic nerve is here. This is the lens, and demarcation of the line here. So this is the retina. And the stage 2, you can see demarcation line widens and thickens. See, this line is widening and thickening now, forming a ridge kind of appearance here. In stage 3, new blood vessels grow. So you can see more blood vessels growth here, but this area is more widened now. And then stage 4, so partial detachment of the retina when it comes here. So now the retina is detached from the globe. This is the globe, eye globe. The retina is detached from here, and then here this is partial detachment. This area is detached, but this area is still attached. And here in stage 5, detached, the whole retina is detached from the globe. So this can cause blindness in the baby. So how do we assess it? Review prenatal history for risk factors. So if the mother have hypertension, or mother was using substance misuse, or preeclampsia, heavy cigarette smoking, or placental insufficiency, so this can lead to retinopathy. Placental insufficiency, like any kind of placental insufficiency, cord compression, or if the mother, even hypertension can lead to placental insufficiency, but placenta is not sufficient enough to provide oxygen to the baby. So assess newborn's gestational age and weight. As we said, newborns weighing less than 1,500 gram or born at 28 weeks, that is less than 32 weeks, are at more risk. Evaluate the newborn's history for duration of intubation and use of oxygen therapy, and then see how many days the baby is getting oxygen, how many hours, and how many, like how long the baby is getting oxygen. Intraventricular hemorrhage and sepsis can lead to intraventricular hemorrhage, so in the brain, and then also can lead to sepsis. So what are the nursing management here? First one is administer oxygen therapy. Cautiously ensure lowest concentration and shortest duration. Don't give them high concentration, give them lowest concentration. Assist with the ensuring ophthalmic exam. So administer mydriatic eye agent 1 hour before appointment. So you know what is mydriatic eye agent is. That is the one we are giving to dilate the pupil. So during the ophthalmic exam, so it's easily visible inside the eye, so to see the retina. And then protect baby's eyes from light and provide support to parents by giving them information and providing details about the condition and follow-up examination. So periventricular intraventricular hemorrhage. So this happens when bleeding in the brain due to fragility of cerebral vessels. So the vessels in the brain is very fragile, so bleeding into the brain can cause in the ventricles of the brain, so that bleeding into the ventricles of the brain, so that cause periventricular hemorrhage. Most common in the first 72 hours of birth. Grades are there from grade 1 to grade 6. So what are the grade 5, sorry, what are the nursing assessment here? Possible no symptoms, sometimes you don't see any symptoms. Risk factors: unexplained drop in hematocrit. You can see there is nothing because it's like into the brain, so you may not see anything, no hematoma or anything. The bleeding is happening inside the brain. So unexplained drop in hematocrit, so hemoglobin and hematocrit can be reduced. Baby looks paler because baby is bleeding. Poor perfusion, seizures, because again the blood is bleeding into the brain, so that can cause seizures. Compression there. Lethargy, weak suck, this baby may not be able to, the suck reflex will be very weak, that baby sick. High pitched cry and hypotonia. Baby cry like in very high pitch, and then also hypotonia, all the muscles are with less tone. Cranial ultrasonography is needed to find out this condition. So nursing management include prevention. So how we can prevent it? Correction of anemia, acidosis, hypertension. So if baby can have anemia here, so make sure correct the anemia. If there is acidosis, correct the acidosis. Hypertension, then give the vasopressors or give the medication to increase the blood pressure of the baby. So flexed contained positioning. So this positioning which mimics the fetal position with arms and legs tucked in aims to stabilize the infant's head and body, reducing fluctuations in cerebral blood flow and intracranial pressure. So that's why we are maintaining this position. By minimizing this fluctuation of the brain, the fragile blood vessels in the germinal matrix of the brain are less likely to rupture, so thus decreasing the likelihood of IVH, intraventricular hemorrhage. Daily head circumference is necessary to measure and record it. Steering care, limitation of stimulation, so do the cares all together. So like clustering of care, so no, not steering, this is clustering of care like any other thing to avoid overstimulation to the baby. Do everything together and leave the baby alone there. And then parental support for possible long-term sequelae. So most of these babies can have long-term complications, so educate them, prepare them for the expected things. This baby can also be lethargy, apnea, bulging fontanelle. When you look at the fontanelle of the baby, you can see it's bulged. Remember before I said the pressure is increased, you can see it's a bulge and a high pitched cry. Then again in this case minimal handling and keep the baby in a midline position. Necrotizing enterocolitis is another condition. 3 pathologic mechanisms here: bowel ischemia, bacterial flora, and effect of feeding. So these all together causing the enterocolitis, necrotizing enterocolitis. From the name itself, necrotizing means that is ischemic, right? The colitis means the colon of the baby, so that is getting necrotized. So bowel ischemia in premature infants, reduced blood flow to the intestine can occur due to heart defects. Sometimes it's a patent ductus arteriosus or birth asphyxia or hypothermia during surgery. So anything can cause ischemia. So poor blood supply to the baby. So so that can cause poor microcirculation. That means circulation to micro small organs. That can cause inflammation and imbalance between vasoconstrictors and vasodilators can cause hypoxia, tissue injury, and disease spread here. So bacterial flora dysbiosis, premature infant can often delayed or abnormal gut colonization because their gut is not matured enough yet, with more harmful gram-negative bacteria and fever proactive species. So sometimes bacteria flora, if there is bacteria flora, in the gut we have a normal flora and the disease flora, right? So normal flora actually help to fight against the like a negative flora, or the flora bacteria which is coming to attack the body. So in case of premature, because that they don't have enough normal flora, so that because of that the bacteria can invade there and cause infection. So this weakens the intestinal barrier, allowing bacteria to invade, triggering excessive inflammation and tissue damage. Feeding effects: formula feeding, especially cow's milk based, increases NEC risk. If the baby is feeding with the cow's milk, that's why we prefer not to give cow's milk for 1 year. Immature intestine may not process cow's milk formula very well, promoting bacterial growth. Sometimes when we give the milk, it can have bacteria there, and the baby won't be able to take that. Feeding increases oxygen demand in the gut, and also when we give feeding, so that demands the gut oxygen demand in the gut. That means that now the gut need to work, so for any organ to work, need more oxygen. If blood flow can keep up, hypoxia and injury may result. So here in necrotizing enterocolitis, remember, so the three conditions are the main pathologic mechanism. So maybe bowel ischemia, bacterial flora, and effect of feeding. So in nursing assessment, look for abdominal distension or tenderness, bloody stools, feeding intolerance, bilious vomiting, or sepsis, lethargy, apnea, shock. So when we do the KUB, shows air in the bowel wall and dilated bowel loops. So that's also causing suspicion of necrotizing enterocolitis. So nursing management here: maintenance of fluid and nutritional status, bowel rest and antibiotic therapy. IV fluids also needed. Remember, baby maybe not be able to feed properly, so give IV fluids to keep them hydrated. Surgery with proximal enterostomy. So sometimes they have to do the surgery may be needed here. In this case of enterocolitis, sometimes they have to make in some cases they have to remove the area which is necrotized. So necrotized means that's ischemic, that part is not good. Or sometimes they have to do enterostomy, so they have to create a ostomy for the for the like a colostomy to the baby. So supportive care needed here, so like oxygen, hypothermia, prevent from hypothermia, quiet environment, cluster the care, and then also family education here, because it's very distressing for the family. So teach them about the condition, teach them about the prognosis of the baby. Infants birthing parents with diabetes, high levels of maternal glucose plus crossing placenta, stimulating increased fetal production, insulin production, leading to somatic fetal growth. So here, because of the increased maternal glucose, and that increases the fetal insulin production, leading to somatic fetal growth. So people with the infants from diabetic mothers, they are macrosomic, big babies. Nursing assessment: birthing parent with diabetes. So assess the parent's diabetes and full rosy cheek. So you can see a rosy cheek, ruddy skin color, short neck, buffalo hump, massive shoulders, distended upper abdomen, excessive subcutaneous tissue fat, and then hypoglycemia, and sometimes birth trauma. Why birth trauma? Because it's a big baby. Sometimes that can cause. Sometimes they have to use forceps and vacuum to deliver the baby. So that can cause birth trauma to the baby. Hypocalcemia, the decreased calcium level, decreased magnesium level, polycythemia, increased levels of hematocrit or hemoglobin, and then hyperbilirubinemia, also bile production is increased, also can be noticed in this baby. Infants of birthing parents with diabetes mellitus. So nursing management here, prevention of hypoglycemia. So make sure check the blood sugar frequently, give oral feedings, and then neutral thermal environment and rest periods, and cluster the care. So, and then maintenance of fluid electrolyte balance, calcium level monitoring, fluid therapy, and then give enough fluid, and then bilirubin monitoring to maintain the fluid electrolyte balance. And then the parental support and education is needed because it's equally supportive, sorry, equally distressing to the parents. So now newborns of birthing parents with substance abuse disorder. Most common causes include use of substances like tobacco, alcohol, and marijuana. So you can also see fetal alcohol syndrome here. So physical and mental disorders appearing at birth and remaining problematic throughout the child's life. Preterm infants have a delicate vascular structure. Fluctuation in blood pressure or oxygen can rupture blood vessels, bleeding to vessels. So, fetal alcohol spectrum disorders. We talk about the fetal alcohol spectrum disorders in the last class. Alcohol-related birth defects, neonatal abstinence syndrome, drug dependency acquired in the utero manifested by neurologic and physical behaviors like seizures, jerking movements, and then high-pitched cry. All this can be expected in children born to substance abuse disorder parents. So, what are the nursing assessment and management for newborns of substance abuse disorder parents? So nursing assessments are maternal history, see what kind of medication the mother was taking, how long she's taking, when was the last time she took it, whether she took the medications during the time of delivery. So risk behaviors, what she's what kind of behavior is prompt her to take substance abuse. Toxicology, sometimes the substance abuse drugs level may be high in the mother, so look for the toxicology report. Newborn behaviors, withdrawal assessment. So newborn here having the fetal alcohol withdrawal disorder symptoms, so look for, and then if you go to box 24.3, so the chapter newborn behaviors for a birthing parent with the substance abuse disorder is there. Withdrawal assessment. Nursing management, comfort promotion, stimuli reduction, the nutrition, prevention of complication, parent-newborn interaction. So don't leave the baby like that. Make sure even the mother is substance addicted or something. So always make sure the baby can create some bonding with the parent. So now we see about birth trauma, injuries due to the forces of labor and birth. That's called birth trauma. So types may be fracture, brachial plexus injury, cranial nerve trauma, head trauma, or cephalohematoma, caput accidentum. So types of fractures means when the baby deliver, for example, if they have a shoulder presentation, the shoulder can break, the shoulder bones can break, and brachial plexus injury. So when you pull the baby with the hand, that can affect the brachial plexus of the baby on the hand. And then cranial nerve trauma, so when they're using the forceps or vacuum, so that can affect the cranial nerves. Head trauma from a forceps and vacuum again, and then sometimes in that can go cephalohematoma, caput accidentum. Many times I explained in the class, cephalohematoma is the one it's not crossing the sutures, caput accidentum crossing the sutures, and then cephalohematoma is more serious than caput accidentum, because caput accidentum is fluid collection because of the pressure from the delivery time, but usually that will go away after some time. Nursing assessment, rules for the risk factors, physical and neurological assessment, bruising, look for any bruising, bumps, swelling, paralysis, symmetry of structure and function. So what are the nursing management here? Supportive management, assessment of resolution of complication. So making sure whether the capisaxidinum or the fracture, whether it is resolving, and then support and education. Tell the parents, the babies need to go home with capisaxidinum. Teach them what it is and then how long it will last, and then what to be expected and what to report. Realistic appraisal of situation. So what is the real situation is going on, so based on that do the nursing management according to the situation of the baby. Community referral for ongoing follow-up and care. So if the baby is discharging home, making sure they ask to come follow up with the local provider or OB/GYN doctor or PCP. Hyperbilirubinemia, imbalance in the rate of bilirubin production and elimination here. Total serum bilirubin level is more than 5 mg per deciliter. So I talked about this a little bit in the class. So this can be hyperbilirubinemia, can be physiological jaundice that usually develop third or fourth day of the life. So is early onset breastfeeding jaundice and then late onset breastfeeding jaundice. It can be both, sometimes started once the baby started breastfeeding. So pathology, jaundice that occurs within the first 24 hours of life. So that's the difference between pathological and physiological jaundice. Physiological jaundice occurs third to fourth day of life, and pathological jaundice occurs within the 24 hours of life. So baby can have a kernicterus, so that is the yellowish kind of skin discoloration. You can see a rare permanent form of brain damage can cause because of that in newborns, caused by untreated severe jaundice. And then this occurs when there is high levels of bilirubin. A yellow pigment passed to the brain, causing toxic damage. So key symptoms of kernicterus include lethargy, poor feeding, severe muscle spasms, and later movement or hearing disorders. Rh isoimmunization. So Rh isoimmunization is a condition where an Rh negative pregnant person develops antibodies against the Rh positive blood of the fetus. You always seen that in the hospital. So these antibodies can cross the placenta and destroy the fetal red blood cells, causing hemolytic disease of the fetus and newborn, especially that happens to the next baby. So ABO incompatibility is occurs when a person receives blood or more commonly a fetus inherits a blood type of A, B or AB incompatible with the mother's blood O type. Mostly ABO incompatibility in the mothers with the O blood group, prompting the immune system to produce antibodies that destroy the red blood cells, which very frequently causes newborn mild jaundice. So this can cause to mild jaundice. So serious complications are rare, but all these babies need phototherapy. So newborn RBC breakdown is high and the liver conjugation is immature. So bilirubin accumulates, and then also unconjugated bilirubin can cross the blood-brain barrier. That's how kernicterus is causing. And then so with any jaundice, you can see a lowering of the trunk and face. And then here nursing management is early feeding, promotes excretion, phototherapy, and then why phototherapy? Phototherapy helps to convert the bilirubin. Exchange transfusion is if the case is severe. Yeah, we are just repeating that. Hyperbilirubinemia, nursing assessment risk factors. Look for the jaundice, signs of Rh incompatibility, and then bilirubin levels. So what are the signs of Rh incompatibility? So some can be jaundice, anemia, swelling, enlarged organs, lethargy, rapid heart rate, and breathing. And also we need to maintain the bilirubin levels for the baby when they have make sure they are within the normal level during the time of when they are having jaundice. And nursing management, reduction of bilirubin levels, early feeding, and then phototherapy, exchange transfusion. So for babies, for mothers, they need a education and support, and home phototherapy, how to do home phototherapy, and then tell them about the normal bilirubin level. So typically, the you know, during the first 3 to 5 days, it's a typical high, and then often peaking around 5 to 6 milligram per deciliter, and then they come down a little bit. Newborn infections, neonatal sepsis, so can be bacterial, fungal, or viral microorganisms or their toxins in blood or other tissues that can cause sepsis to the newborn. Bacterial, fungal, or viral microorganisms. So we classified, so it's mainly because immature immune system makes newborn highly vulnerable for infection. Infection may be acquired in utero, maybe during the birth or postnatally, after birth. So key signs include temperature instability, poor feeding, apnea, lethargy, and then classification can be congenital, so intrauterine, so that already happened when the baby was inside the mother's womb, and then early onset, prenatal period, late onset, after a few days of birth, so it can develop. Nursing assessment, look for the risk factors, non-specific symptoms, elevated C-reactive protein, and positive cultures, so those are the signs indicating that baby having some kind of, baby can go for sepsis. So if the baby is going for sepsis, then support the airway, circulation, nutrition, all needed. And then how do we manage neonatal infection? Antibiotic therapy, according to the whichever bacteria or the treatment, whichever the organism is growing in the baby's body. Circulatory, respiratory, nutritional, and developmental support is needed here. So for circulatory, so they want to make sure they're not cyanosed, or their circulatory system is working properly. Respiratory, no cyanosis. And then nutritional, they are not hypoglycemic, they are getting the feeding, IV feeding, or gavage feeding, and developmental support. So when the baby is sick, they still need the developmental support for their age. Education for prevention and early recognition, so educate the parents about how to prevent infection and what are the symptoms they can recognize having sepsis, so that they can seek for care earliest. Primary disease prevention, teach them about how can they prevent the disease, is mainly because they can do hand washing, using the clean equipments for the baby, sterilize the feeding equipments, those kind of primary prevention things they can do. Family education also, maintaining hygiene, and then watching for any adverse effects to seek care. So we see about some of the congenital heart disease, 4 physiological categories here. So defects causing increased pulmonary blood flow. So now the defects can cause pulmonary blood flow more. So arterial or ventral septal defect. So when there is an arterial or ventral septal defect, blood can cross from left side to right side. So that cause more pressure on the pulmonary blood flow. So defects causing obstructed blood flow out of the heart, so that's because of aortic stenosis. Blood is producing, but blood is not going to the extremities, to the other parts of the body, because there is some stenosis in the aorta. Defects causing decreased blood flow, so tetralogy of Fallot. So some defects can cause decreased blood flow. So tetralogy of Fallot is a condition. So tetralogy, I think we talked about this in the class. Tetra means four. Then tetralogy of Fallot means four conditions causing the condition. So a combination of four congenital disease. That is, uh, this is mostly because of the this is mostly because of the ventral septal defect, overriding of the aorta. So, and then the ventral septal defect, right? So there is a defect between the ventricles, and then overriding of the aorta. Aorta can be formed from not from one chamber, can be from both chamber. And then pulmonary stenosis, then the pulmonary artery can be stenosed, and then the right ventricular hypertrophy. So because of too much pressure on the right side of the heart, so that can cause hypertrophy of the right side of the heart. That's called right ventricular hypertrophy. And the defects involving mixed, desaturated or saturated blood. Sometimes, there can be defects which can cause mixed blood. So that is cyanotic disease or acyanotic disease. So sometimes, when there is overriding of aorta, or when there is a mix-up of the blood vessels in the baby, that's mostly happening due to the congenital heart disease, congenital problems. So this can cause blood in the chambers, of blood in the vessels can mix together between the between the saturated and the non-saturated blood. So what are the congenital heart disease risk factors? So birthing parent who misuses alcohol, birthing parent with diabetes mellitus, single gene mutation or chromosomal disorders, birthing parent with the exposure to X-rays, birthing parent with exposure to rubella infection, birthing parent with the poor nutrition. So they all can have they all are risk for congenital heart disease. So common types of congenital heart diseases are septal defect, holes in the wall separating heart chambers, atrial subdefect and ventricular septal defect, and valve defects, valves that are missing or maybe too narrow, stenosis or leaking. So complex heart defects such as we talk about, structures may be missing, poorly performed or in the wrong place, such as tetralogy phallic, transmission of great vessels, or hypoplastic left heart syndrome. So, when we hear of transposition of great vessels or transposition of great arteries, means it's a serious rare congenital heart disease condition where the aorta and the pulmonary artery are switched, causing oxygen poor blood to circulate in the body. So it appears at a birth with the cyanosis, poor feeding and birth issues. Immediate life-saving measures are needed, or surgery is needed here for the baby. So mostly like the artery, the no than the normal. So they switch the places of the vessels in the heart. So other risk factors are birthing parent over age of 40, birthing parent use of amphetamines, and then genetic factors. So if there is any genital congenital problems in the congenital heart problems in the family, so that can cause problems uh, in the coming generation too. So amphetamines is when the mother is using amphetamines, so that can, especially during the first trimester, that can leads to congenital malformation. Birthing parent metabolic disorders like a phenylketonuria. So I talk about phenylketonuria in the last case, so that is a metabolic disorder. So when they have phenylketonuria, so then they can have toxicity from that. So that can lead to problems in the newborns also. Birthing parent use of anticonvulsants, estrogen, progesterone, lithium, warfarin, and isotretinoin. All these can cause long-term use of all these can cause problem with the congenital heart disease in the parent. So I said in the last class, phenylketonuria is an inherited metabolic disorder caused by mutation of a gene resulting in the inability to break down amino acid phenylalanine. So if it is can cause toxic buildup of phenylalanine in the mother's blood, and then that can cause intellectual deficiency, intellectual disability, seizures, and behavioral problems, and also that can further create problems to the mother, to the children, and also that can contribute to congenital malformation, heart malformation in the child. Nursing management here: assist with the labs, arterial blood gas, chest x-rays, MRIs, ECG or EKG and ECG, same blood studies. And then provide preventative prenatal care, continuous monitoring of cardiac and respiratory status, as that is what affected the heart and lung is always connected together. Administer medication as needed, and then whatever is based on the symptom management. And then educate and counsel parents on condition and medical plan. So in this case, what are the nursing diagnosis? Key nursing diagnoses are managing decreased cardiac output, impaired gas exchange, and inadequate nutrition due to high metabolic demands and fatigue. And then common priorities here is include a risk of infection, and then activity intolerance and imbalanced nutrition. Excess fluid volume and deficient knowledge deficit is also nursing diagnosis you can consider in a baby with the congenital heart disease, and also for the parents. So neural to other congenital conditions are neural tube defects, that is anencephaly, spina bifida, meningocele and meningomyelocele. I talk about spina bifida, meningocele and meningomyelocele many times in the class. So here anencephaly means sometimes the head is too small, like so when you look at the size of the head, you can see it's a severe fatal neural defect. Here baby is born almost without part of the brain, so you can see the brain is almost not there, or part of the skull is not there, due to failure of the neural tube defect. That is happening during the first month of pregnancy, mainly because of folic acid deficiency. That is the reason we are asking the mother to take folic acid to prevent this kind of neural tube defect during the time of pregnancy. Microcephaly, the baby's head is very small head. Hydrocephalus or cephalus. I talk about hydrocephalus many times in the class. Like when they have too much fluid in the when they have too much fluid in the spine, the spinal fluid in the brain, so that can cause hydrocephalus. Congenital diaphragmatic hernia, so they can have diaphragmatic hernia from the hernial area, so that is a hernia forming through the diaphragm. That is because of the weakness of the diaphragm. Diaphragm is a muscle. So when the diaphragm is weakened, so what is herniation happening? Usually the stomach is herniated through the cardiac sphincter area to the the sphincter area of the through the diaphragm that is going up to create a hernia there. So cleft lip and cleft palate is also a condition here. So that is a congenital condition can create. Neural tube defect, congenital CNS disorders occurs when the neural tube fails to close properly. Normally occurs between the 17th and 30th week of gestation. Anencephaly, I already said what is anencephaly is, like almost absence of the brain there, or brain part, or not forming the skull and brain properly. Spina bifida, everybody knows spina bifida. Meningocele, I said when there is a spina bifida at the spine, lower portion of the spine, so the bone is not fused well. So what happened here, the meningocele is when the myelin sheath, when the is of the uh, myelin sheath of the spinal cord is protruded outside. Meningomyelocele, not just the myelin sheath, that also has the myelin sheath and the meningeal cover and the nerve part also in the meningomyelocele. So always remember, meningocele is just the meninges of the spine. Meningomyelocele is meninges and the myelin sheath of the or myelin part of the um, nerves. Risk factors, celiac ancestry, that's maybe because of the hereditary problems. Females, birthing parent with diabetes, low socioeconomic status, anticonvulsant use, low folic acid intake. That's the main reason we are asking the mother to take folic acid before even they're starting to get, even at this time of they're planning to become pregnant. Birthing parent with obesity, birthing parent with the malnutrition. So when the baby having a neural tube defect, so risk for they can have a risk for infection. For example, spina bifida. So the cover can the spina bifida can the meningomyelocele can rupture, right? So what is the nursing care here? Cover the sac with sterile moist dressing. So because that is a mucous membrane, you don't want to get it dehydrated and cause ulceration, right? So make sure it's covered with the moist saline dressing and prevent infection and trauma, and that results in exposed malformed structures like spina bifida. Risk increased like when the risk of ulceration is increased when the baby is on their back. So don't put them on their back, make sure they put them on their abdomen. Cleft lip and cleft palate here, see the picture, you can see the picture in the next slide. Cleft lip involves fissure or a opening in a lip. Cleft palate involves roof of the mouth. So cleft lip involves just the lip. Cleft palate, when there is a cleft, there is an opening, a fissure in the roof of the mouth too, and the palate of the mouth. So most common craniofacial birth defect is cleft lip, and then therapeutic management here, cleft lip surgical repair between the 6th to 12th week when they have 6 to 12 weeks, and cleft palate surgical repair between 6 to 18 months. So there are a lot of surgeons that are doing this now. So they have very effective surgeries are available for this one, because this cleft lip can cause a lot of problem with the nutrition with the baby, breathing, appearance. It's for the mother, for the baby, it's very distressing for them. So it's better to repair it earlier, even before the baby start realizing it. So that can create confidence in them. So nursing management provide adequate nutrition and parental education, because nutrition is a big problem. Baby cannot suck to the breast because of that cleft there, cannot make a good seal around the breast. And then promote parental bonding, because sometimes parents like, oh, why the baby look like, I don't know, I can't believe this is my baby. Sometimes they don't have the bonding between because of the baby's look, but promote them and then support them. See, this is the picture of a cleft lip and a cleft palate baby. So esophageal atresia and tracheoesophageal fistula. So here this is common lack of normal separation of esophagus and trachea during embryonic development. So so what happened? Trachea and esophagus are nearby adjacent organs, right? So during the embryonic development, so it won't separate into esophagus and trachea. So there can be some joining between the trachea and esophagus. What happens when there is trachea and esophagus joined, or there is connection, or it's not there? So what happened? So if the trachea and esophagus is connected, from esophagus food can go to trachea and can cause like aspiration to the baby, and our esophagus air can go to the patient stomach, can cause gaseous distension, right? Sometimes, so there is another condition where there is a blind end of the fistula, of the fistula. So that means esophagus is not connected anywhere. So the esophagus is connected to trachea. That's even worse. Esophageal atresia congenitally interrupted esophagus and tracheoesophageal fistula, abnormally communication between trachea and esophagus. I'll show you the picture in the next slide. So nursing assessment here for hydramnios, if they have a lot of fluid in the stomach. So why hydramnios here? Sometimes so the babies can the fluid, baby maybe like usually what happen, baby swallow some of the amniotic fluid, right? So that's why baby pee, right? But here baby swallow, but it may not be going to the esophagus because there is no connection. So you can see why there is no reduction in why the baby is not using or like drinking any of the amniotic fluid, because there is a congenital problem where the fluid is not going down. I'll show you the picture. So copious frothy bubbles of mucus and drooling. So abnormal distension because baby is having a lot of bubbles and mucus, because remember trachea and esophagus is connected together now, so that can cause drooling, mucus, aspiration, abdominal distension, because from the trachea now like fluid or whatever can come to the baby's stomach. Once the baby coming out, once the baby start breathing, and then now actually the breathing air can from the trachea that can goes to esophagus. That should not go to esophagus, right? That should be going to the lungs, but that can goes to esophagus now. So coughing, choking, and cyanosis can occur here. See here, this is the tracheoesophageal fistula here, esophageal atresia. Here, see, this is the esophagus. So esophagus is atresia. See, there is no connection. Now the esophagus is stopped here. And then here is esophagus. There is no connection. Even the baby eat food, so there is no way the food to come to the esophagus here. Okay, that's called esophageal atresia. Atresia here. Atresia. This is called atresia. And also tracheoesophageal fistula formant. So the esophagus and the trachea, there is a fistula. There is a connection between esophagus and trachea. That's called tracheoesophageal fistula. Congenital GI abnormalities, esophagus and the trachea don't separate normally. See, that is not separating normally. That's like this. So this is what esophageal atresia and tracheoesophageal fistula. So nursing management here, preparation for surgery. Of course, they need surgery and preoperative care. NPO, head elevation, because they can aspirate, hydration, fluids, because they are not getting any fluids, because there is atresia, there is no opening in the esophagus for the fluids to go down. And then also hydration and fluids should be given through IV. Oxygen and suctioning equipment available because they're continuously having bubbles and frothy coming through the mouth. And then comfort measures, parental education, post-operative care. So like in any other conditions, so baby may need to go to NICU until they get better, because that can affect their, because it's trachea involved, it can affect their breathing also, so they may need artificial ventilation for a couple of days. TPN and antibiotics needed. Oral feedings usually usually start within 1 week. Parental teaching is needed here. Omphalocele and gastroschisis. So omphalocele, I talk about omphalocele many times in the class. It's an umbilical ring defect with the evisceration of abdominal content. Evisceration means coming out, right, into external peritoneal sac. So that means there is the muscle ring and the umbilicus is not formed. So the abdominal contents is outside, coming outside. So you can see it from outside. There is no abdominal muscle there, abdominal covering there. So gastroschisis is a herniation of abdominal contents through abdominal wall defect, no peritoneal sac. So in this area there is no peritoneal sac. So the abdominal contents are coming out through herniated through the there is a small wall defect. The uh, abdominal contents are coming through, but here in omphalocele there is a peritoneal sac, so all the organs are within the sac. But gastroschisis, there is no peritoneal sac through the for example the intestine is coming out like that. Nursing assessment, risk factors, protrusion of abdominal content, sac, evidence of other congenital abnormalities. Sometimes when the baby have one congenital abnormalities, they can have another, because sometimes the organs develop at the same time, so that can cause a problem to other organs developing at the same time too. Nursing management here, preoperative care, preventing hypothermia, maintaining perfusion to abdominal contents, because that is like a mucus area. So how do you maintain perfusion? Abdominal contents, so cover it, protect exposed contents from trauma. Here, omphalocele, see here, umbilical ring defect. There is an umbilical ring defect. Abdominal content protrude into the peritoneal sac. See, so the abdominal content is protrude. There is a sac there, through the sac, the abdominal content is coming outside. Gastroschisis. So see, here is also there is a small area of weakness. Through the weakness, abdominal contents slip outside without a sac. There is no sac. Here is a peritoneal sac covering the organs, but there is no sac. See here, the intestine is coming out like that. Next one is imperforate anus. So rectum ending in blind pouch or fistulas between rectum and the perineum. So there is, anus is not perforated, So yeah, rectum ending in a pouch or fistulas between rectum and perineum. They can cause fistulas. It's not opening into the anus area, anal area. Assessment, absence of anal opening, passage of meconium. In this case, if the baby is not passing meconium for a couple of hours, you need to see whether the baby having a anus, intact anus, or maybe the anal opening may be opening into the rectum. Maybe into the perineal area or to the vaginal area, so look for that. So signs and symptoms of intestinal obstruction. Sometimes there is baby cannot pass meconium. It's same like the obstruction there. So you will see the signs and symptoms of obstruction, like abdominal distension, and then vomiting. Patient keep vomiting. Those are the signs of intestinal obstruction. Nursing management, preparation for surgery, post-operative. For example, these patients, definitely they need a preparation of surgery to correct the problem, because they cannot live long without passing meconium. Bladder extrophy, this is another condition. Protrusion of bladder on the abdominal wall, same like omphalocele, whether the abdominal organs are coming out. This is more on the symphysis pubis area, separation of rectus muscle and the symphysis pubis here. So what happens here, this abdominal, the bladder is extrophy, bladder is protruding outside. You can see the bladder from outside, but there is no abdominal wall over the bladder. So males also with the epispadiasis. Epispadiasis means what? So the opening of the urethra on the upper side of the urethra, penis. So initial bladder closure within 48 hours of birth, further construction at the age of 2 to 3 years. So in this case, so they do the initial bladder closure. They have to do it initially, because what happens, because the whole bladder is outside. That's not good for the baby. It can cause infection and die soon. So they have to do the initial closure by 48 hours of birth, and then if they need any other reconstruction, they do that when the baby gets a little bit older, 2 to 3 years of age. See, this is a bladder extrophy. See how it is looking like. So now the umbilical cord is here, exposed bladder. See, the bladder is exposed here. There is no skin around on the bladder, because for us the bladder is under the skin, but the skin is not there, so the bladder is outside. Exposed urethra. See, the urethra is exposed here.